Tackle Talk, the men's health podcast. Three guys tackling all things men's health head on.
Today we're talking about vasectomies, and I'm joined by Trent Barrett, who's another urologist. Hi, Trent.
G'day, Andrew.
How are you going?
Good, mate. I'm better after this coffee you've made.
Yeah, it's nice coffee, isn't it?
What beans are you using?
Those are the Fat Puppy beans by Left Field. If you're out there and you want to sponsor this show, just get in touch.
That's Perth, is it?
Yeah, it is.
Great.
Yeah, Perth, Western Australia.
I approve.
We're getting up there in the coffee stakes, I think. We're almost as good as Melbourne.
We like to think so.
They might disagree. So talking about vasectomies, I was reading the other day that it's one of the most popular surgical procedures in Australia. There's something like 30,000 done each year.
Extremely common and, becoming more so across the world. In the USA, there's new legislation which makes it appealing not to have an unplanned pregnancy.
Yeah, and guys are taking more responsibility for fertility or control of fertility, not just leaving it up to the ladies.
It's a positive change.
Yeah, so what is the typical guy who would sort of come to you requesting a vasectomy?
Look, there's quite a wide range of guys who want a vasectomy, but the typical patient would be a man in his late 30s who has completed his family and either he or his wife or partner doesn't want to be on reversible contraception.
Yeah, so what are some of the problems with reversible contraception, like condoms, for example? I mean, we all know they can break, they can slip off, or, there must be a fairly high failure rate with condoms.
If you read the fine print on the packaging, it's scary. It's about a 3% failure rate. And some of that's to do with usage and, user error. A lot of the problems with condoms are to do with the user experience. People don't like to use them, that they ruin the spontaneity and, long term, it's an uncommon choice for people to make.
Yeah, but certainly very important from an STI point of view for sexual health. But if you're in a committed relationship and you don't want to use condoms, that leaves other options which might be female-based, such as the female contraceptive pill that's been around for a long period of time. But there can be problems with that as well, can't there?
Well, I think typically we've leaned quite heavily upon the female role in contraception, like you were saying. And all female reversible contraception relies on some sort of hormonal mechanism. So, there are problems with this, not only in terms of the failure rates, which are higher than any surgical intervention, but also to do with the experience for the woman in the sense that there's side effects. All hormones carry some sort of risk and side effect, even though it might be low, usually well tolerated. Mood changes, weight gain, things like that, not always preferable.
Yeah, I think all women out there are probably well versed in the side effects of contraceptions and that they can be fairly mild or they can be quite significant and potentially life-threatening. For example, with clots in the legs or, causing potential thromboembolism. And in some women, they just have been told by their doctors, you should not be taking oral contraception.
It's true, but probably the majority just don't like whatever side effects they're getting.
So in terms of permanent contraception, vasectomy is the best in terms of success rate, but it's certainly a lot easier to perform than perhaps compared to the permanent contraception option for a woman, isn't it?
Well, look, there's two benefits to vasectomy as compared to the option for the female partner, which is tubal ligation or tying the fallopian tubes. One is that the success rates are much higher. There's about a 10-fold higher success rate in terms of preventing long-term failure with a vasectomy. And also the organs we're operating on, the vas deferens, which is the tube that carries the sperm from the testicle up towards the ejaculation ducts, is easily accessible through the scrotal skin. There's about 1 millimeter of scrotal skin between the weld and that tube. So it's much less risky than a intra-abdominal surgery, which would be required to get to the tubes in the female.
Yeah, it's a much bigger deal for a woman. So in terms of talking to patients about a vasectomy, because it's a permanent contraception, what sort of things do you go through with them? Obviously, you want to check if they've completed their family and they don't want any more children.
Gee, it's a long discussion in terms of counselling a patient and their partner about the vasectomy. But the first thing I'm looking for really is their motivation for it. And I'm trying to identify any red flags that could lead them to regret their decision, because I'd hate to be responsible for someone regretting their decision.
Yeah, absolutely. So what are some of those red flags you're looking for?
Well, typically, like we said, the man is in his later 30s, has completed his family. Sometimes that happens earlier or later, depending. But so certainly a very young man or a very young female partner or someone with very young children probably has more risk of regret than someone who has had more time to think about their family planning and satisfy themselves that it's concluded.
Yeah, how often do you get a guy coming in who he and his partner have just had a newborn baby and it might be their third or fourth child or even their second child, and he's really stressed out because they're not getting any sleep, and he and his wife are thinking, boy, we really don't want any more children. Is that a good state of mind to make that decision in?
Look, I tell those guys that no men want another child when they have a screaming infant in the house, right? It's reasonable.
Yeah, absolutely.
So, maybe let that cool off for a bit, let the child grow up a little bit, let things settle down, and then make a decision which is permanent. And in the short term, those reversible options that we spoke about, they're reasonable.
Yeah. Okay, so what else are you interested in when you're talking to a male who's coming in requesting a vasectomy?
Well, look, sometimes the conversation can deviate when I meet somebody who doesn't have any children and wants a vasectomy. I think, I can respect where they're coming from and I can understand where they're coming from in a lot of cases, but it requires a little bit of extra counselling. I'm looking at their medical risks to make sure that a surgery is a good idea for them. Looking at their anatomy to make sure that the surgery can be achieved safely. And I'm looking at their expectations and making sure they understand that vasectomy has limitations. It's not perfect. Although it's the best thing we've got, short of, buying a new house with 2 separate bedrooms, it's, the lowest possible failure rate for a type of contraception. So they need to understand that there is a risk of long-term failure, although it is very small.
Yeah, so once you've examined them what are you looking for in the examination, by the way?
Well, look, men have testicles that sit in all different positions. Some hang low, some high up, some jump around. You want to establish that they're going to have a vas that's easily accessible without testicular retraction or spasm or trouble during the operation. This is more of a problem when someone's having the operation awake. If they're having the operation asleep, it sort of counteracts a lot of these problems in that the body's relaxed, the vas is relaxed, and it's much easier to access. But, certainly if someone wants the operation awake, this plays a big part.
Have you ever come across a situation where you couldn't feel the vas?
Look, it's very rare, but I have. The sort of things which are rare, but I'm looking out for are, the testicular health. There's been a case where I've diagnosed a testicular cancer on a routine vasectomy examination. And as you alluded to, congenital absence of the vas, which means you're born without a vas on either one or both sides. You're missing one, well, we can explain that. If you're missing both, it's a difficult discussion in terms of their previous family.
Yeah, and it's a good opportunity for just a general male genitourinary health checkup at the same time. So you've established that they've got the right motivations to have a vasectomy, that it's going to be fairly straightforward from an anatomical point of view. What are the options in terms of actually proceeding? You talked a bit about having it under a general anesthetic or under local anesthetic. What are the pros and cons of each?
Well, here's the thing. I mean, the operation is exactly the same regardless. So personally, I don't really have a strong preference as to which is better in terms of the surgical outcomes, although in some people who have a very retractile scrotum or who have any anatomical problem with the scrotum, like previous scarring from other surgeries or injuries, a general anesthetic is much better. So those people are strongly encouraged to be asleep. In the rest of the population, it's really a preference about what sort of experience you're gunning for with your vasectomy. Being awake, the biggest problem is that you've got to have local anesthetic injections to numb the testicles while you're awake. And having needles in the groin or near the genitals is confronting, and a lot of people don't tolerate it that well. So, that's the biggest problem with a local anesthetic procedure that I can see. And it's really hard to pick sometimes the people who are going to have problems. People come in showing a very brave face. And it's sometimes these guys who are really, really, outwardly brave and pushing strongly for a local anesthetic procedure who then have a problem on the day where they don't tolerate it, and there's a risk they may faint or have pain during the operation or other complications, which I just want to avoid.
Yeah, I mean, I can speak from personal experience having had a vasectomy, and I opted to have it under local anesthetic because I didn't really want a general anesthetic interfering with my busy day. But I must admit that as the needle was approaching my genital area, I did have a bit of regret and think maybe I should have gone for the general anesthetic. But it was just momentary discomfort. If anybody's had a local anesthetic injection, there's a bit of a sting and then it goes numb fairly quickly. And my surgeon, shout out to Rob Davies, who's an excellent vasectomist, did a really good job with the local anesthetic, and I just watched TV while he did it. I will say that if you have it under local anesthetic, you might smell your skin or tissue burning, as they use diathermy to control the bleeding, which was a little bit confronting, even for me as a surgeon.
Gosh.
But what it did allow me to do was just get up and walk out straight away. But on the downside, I didn't receive any sympathy from my wife, because I got a call as soon as I was walking out of the clinic, and she just said, "How did it go?" "Yeah, that was fine." She said, "Okay, well, can you go and pick up the kids from school, go and get this from the shops on the way home, blah, blah, blah." And while I was waddling down the street, slightly uncomfortable with a numb feeling.
No, you need a bit of sympathy for sure. You know, I really try and impress upon patients. They mustn't under sort of play this procedure. It is an operation. It is a surgery on your genitals, and there are small risks of complications, and all those risks are higher in someone who, you know, does something the same day and walks too much or does physical activity. So I think it's a delicate surgery that's best done correctly once, and you don't want complications in that area. You don't want pain in that area. You want everything to go as smoothly as possible. So when talking to people about their anesthetic choice, I'm really happy to give them a general anesthetic. I think they are then guaranteed to tolerate the procedure well. There's no variables. There's no variables from the surgery from my point of view, because their testicles are going to be relaxed and accessible. And I just see people tolerating it really well. It's like flying to Europe. You know, you can choose to fly business class and have a nap and you wake up when you get there, or you can sit down with the luggage in the luggage compartment and bounce around for the period.
Yeah, nice if you can afford it these days. Yeah, look, I think the thing about general anesthetic, you're going to put a lot of local anesthetic in there afterwards. They're super comfortable after the procedure.
With general anesthetic, I can look them in the eye and say, look, you're not going to be anxious. You're not going to have pain. You're going to wake up feeling really good. You're going to go home feeling really good. And then you'll have the onset of some discomfort, maybe 10 to 12 hours later. And, you know, you just got to limit your activity and not run into trouble after that.
Yeah, I mean, and let's face it, most guys are pretty anxious about this procedure. It carries a lot of anxiety that you're going and touching their manhood or their nether regions, and the less anxiety that can be brought on by the actual procedure, the better, the more relaxed they feel. And they're often relieved by the fact that you're going to do it under general anesthetic. So what do you tell them in terms of post-operative recovery? What's your advice on what they should or shouldn't be doing in the hours and the days after the operation?
Well, like I hinted at, I think they should really take it easy, because you can prevent problems, but it's very hard once you have a problem to unwind that and sort of forget that experience. So taking it easy in the first couple of days after the surgery is a must. So picking the kids up from school, not a good idea. I tell people to go home, take it easy, walk from the couch to the TV, you know, to the fridge and back, but not too much more than that if they can avoid it. It's a trap, particularly in the first 12 hours when that local anesthetic is still working. People feel close to 100% fine, and they're then tricked into doing too much, and you pay for it the next day and the day after that.
Yeah, I felt great afterwards, but yeah, once the local anesthetic wears off, you do feel a bit uncomfortable. I found the hardest thing was getting in and out of a chair or getting in and out of the car. And so you really just have to listen to your body and take it easy until probably about 4 or 5 days after the procedure, you're starting to feel a bit more normal again. But this is assuming everything goes according to plan, because, you know, potentially complications can occur. What are those complications? What do you warn people about?
So look, the risk of complications is really low, but this is taking a population of patients who I speak to about it really carefully and tell them to avoid doing too much too soon. So in my hands, the risk of bleeding, which is the most common complication probably after a vasectomy, is less than 1 in 500. Most people might have a little spot of blood perhaps on the dressing and maybe some small bruising around the access point on the scrotum, but they shouldn't have much more than that. But like I said, this is people who are advised to take it easy for a couple of days and avoid physical activity for about a week.
Just in terms of that bleeding or bruising or swelling, is there any evidence that applying ice packs is useful?
Not sure about that. I don't really impress the need for ice packs too strongly upon patients. I think there's a slight problem with using ice packs in that there's a risk of leaving them on too long, particularly when the scrotum's numb. You know, you can't get that feedback that it's freezing, and you may leave them on too long and cause damage to the skin. They relieve a bit of swelling and things like that, but I don't tell my patients to use them, and they do fine.
Yeah, okay. Cool. So in terms of immediate complications, we're talking about bleeding. What about infection?
Infection is similar. It's less than a 1 in 500 risk. I do the operation through what's called a no scalpel method, where there's a very small window made on the front of the scrotum to operate through, less than a couple of millimeters. It requires one dissolving stitch, or sometimes not even a stitch to close. And because it's such a small incision, so minimally traumatic, the risk of infection is really low.
Yeah, that's a really tiny incision that you make. I've had some patients comment that they weren't even sure that they had an operation because they couldn't find where you went in.
The proof will be in the pudding a few months later when they have unprotected sex and see what happens.
So, yeah, just touching on that, are there going to be sperms around straight after the operation? What do you advise patients to do in terms of their contraception?
So, look, there's guaranteed to be sperm around immediately after the operation. We've divided and interrupted the flow of sperm from the testicles upwards, but there's a backlog of sperm that you've preloaded which require up to 3 months or more to wash out. So for the first few weeks, I tell people to expect to be fertile. And for that reason, for the first 3 months, you've got to use contraception still, either something from the female side or condoms, to let all that backlog wash out. There's an additional risk in the first 3 months while the body's healing that the tubes have a small chance of rejoining. That first 3 months, the failure rate's about 1 in 200, which is low, but not insignificant. So it's another reason for 3 months you've got to use condoms or something else until we do a test and show that you're clear.
1 in 200, that seems quite high to me. Is there anything that you do to decrease the risk of that other than making them wait?
So the procedure is very thorough in the intention to interrupt the passage of sperm. But, the evidence is despite doing whatever you may do, there is this early risk. And it's because the body wants to heal and it wants to put the vas back together. It wants to make more babies. So for that first 3 months, you've got to be careful. That 1 in 200 number is interesting because that's sort of what we accept with other types of contraception. So like a tubal ligation where the female has her fallopian tubes clipped or tied, that's kind of the long-term failure rate. That's about as good as it gets with that. And if you look at other things like hormones and condoms, the risk is much, much higher, single-digit percentages.
Okay. So how many ejaculations or how long is it going to take to clear these sperms out on average?
We say 20 to 30 ejaculations over 3 months. I think that gives people something to work towards and to keep them busy. You still see some lingering dead sperm in the ejaculation after 3 months in maybe 2 out of 10 men. In those men, that may persist for a long time because they might have had a bit of sperm wash back into some of the ejaculatory ducts higher up that are quite complex and difficult for the sperm to drain out of. And what we do in those men is really just do another test to make sure the sperm are truly dead and then reassure them that the failure rate with lingering dead sperm is actually the same as if there were no sperm long term.
Yeah, so you're looking at the motility of the sperm, and when they're dead, they're non-motile, aren't they? So they're not moving or they're not beating their tails, they can't swim.
Exactly right. It sort of indicates that they died a long time ago and they're lingering for reasons that are perhaps unclear, but the risk of pregnancy is low. So we can give what's called special clearance, where we say, well, you've still got these, they may be there for a while, we know they don't make babies, and we say that's good enough.
So say you get someone who comes back after a couple of weeks and says, I've had 20 to 30 ejaculations. Is that okay to check then, or you'd still advise them to wait the 3 months?
So the 3 months is for two reasons. It's not just to clear the backlog, it's also to allow the body to heal in a way that doesn't lead to a failure. So we've got to wait the 3 months, make sure things settle where we left them, and then give clearance.
And are you happy with one clear sample, or you want them to have two?
This is a bit of a moving target in that the guidelines are changing. The American guidelines, which I think are very well-researched and evidence-based, say that one ejaculation sample at about 3 months is okay, as long as there's no live sperm or very small numbers of dead sperm. In my personal practice, I like to do one more test in the patients who have small numbers of dead sperm because there's a gap between doing the sample and taking it to the lab where potentially the sperm may have been alive when it came out of you and then died on the way. So another sample reassures me that that's not happening. That's outside the guidelines, but it's what I do.
But one sample that shows zero sperm, complete what they call azospermia, that's okay to leave it at that?
At 3 months, that's fine.
Okay. So we hear about long-term complications. What do you warn patients about in terms of long-term complications? And probably the one that most men fear is having chronic pain.
Absolutely. So we spent a bit of time talking about this because in my mind, this is, apart from failure, probably one of the worst things that can happen after a vasectomy. Thankfully, the rates of chronic pain are really low. And chronic pain is very interesting because when we talk about chronic pain, what we're actually talking about is pain at 3 months after the procedure. That's when we can call it chronic. And I follow everyone up quite closely and ask them all the question directly at 3 months. Do you have any pain that's lingering on? And perhaps 3% of them say they do. So it's a moderately high number, although it does mean that 97% of people are getting away with no pain at all by 3 months. Of the 3%, breaking it down, asking them, well, we asked you about this and you told us, but would you have brought it up on your own? Does it actually bother you? Do you actually want medicines for it? It's only 1% of my patients that actually, have bothersome pain at 3 months. And those men get some medical therapy, some painkillers to treat it. Over time, that number goes down. So if we follow them up a month later, half of those men are better. And if we follow them up a month again, another half are better. So they get better at a rate of about 50% per month. So the risk of long-term pain, which is what we sort of instinctively think about when we say chronic pain, is extremely low. But it is absolutely a possibility. Now, is it specific to vasectomy? That's what I have a question mark about, because I think, I've seen patients with chronic pain, which is a large part of my practice, is dealing with these patients and treating them. I've seen patients with chronic pain in the scrotum from all sorts, from hernias, from other scrotal surgeries, from trauma, from infections, and a large portion, maybe 25 to 50% of patients who I meet, no cause at all. So to say that vasectomy with a 3% absolute maximum risk at 3 months is a bigger cause of chronic pain than anything else, I think is questionable. And there's some interesting evidence when they take healthy men who are presenting for a vasectomy and say, well, you're here, we haven't done anything to you yet. Have you had any pain in the last year in the scrotum? About 9% of people have. So there's a background rate of having discomfort in the scrotum, which people experience and probably don't focus on. They dismiss. They go, oh yeah, that's a bit weird. And they move on because they haven't had an operation. But after you've had an operation, you fix your attention on that and you sort of find a culprit and you have a cause and you fixate. And I think that's part of why it's more bothersome.
Yeah, so as long as they're counselled about it and reassuringly it is very rare and, can be treated if it comes up. Is there anything in your technique you think that decreases the risk of chronic pain? Is any of it technique dependent?
Gosh, this is getting very controversial because there's no evidence that something is better than something else in terms of chronic pain with vasectomies. The way I do it is aim to reduce the risk of chronic pain. A lot of that is based around trying to reduce the risk of pain at the time or pain immediately after the vasectomy. So having it done with good anesthetic coverage, whether it's local or general, and then recovering in a way that doesn't trigger pain. So not doing anything too soon, taking regular painkillers and really looking after yourself. That decreases your risk of having pain in the first couple of weeks. And I think if you haven't had pain in the first, couple of weeks or your pain settles down over the first few weeks, then it's much less likely you're going to end up with long-term pain. A lot of patients who I see who've had chronic pain after a vasectomy from elsewhere or wherever I see them from have had a really bad time with their vasectomy. A large portion of them have had a traumatic experience, usually under local anesthetic, where they felt pain during or after the vasectomy or had some complication because they returned to work too quickly or similar.
Yeah, that does seem to be a component in chronic pain generation, is that there's been some event which has really fired up the pain fibers to some degree and then they've developed chronic pain as an ongoing problem after that.
I think controlling as much as we control, as much as we can control is important. And, that is the operative experience, that is the post-operative experience. And from there, I think there's an element of chance.
Okay, I'm going to be controversial again. Vasectomies can be done by GPs or specialists. Who do you think should be doing them?
Look, I wouldn't say that's controversial. I think vasectomies can be done by anyone who can do vasectomies well, right? So I think the majority of them are done by non-specialists, by general practitioners, and the highest volume vasectomy practitioners probably do it very well. So I don't think there's a problem with that. I think they do it in a way which perhaps has limitations in the sense that they don't have access to a theatre with anaesthetic, so there's probably a push to do it under local anaesthetic, which is not a good fit for everyone. So maybe there's a problem with doing it in everyone that way, but in terms of their technique and performance and the outcomes, I'm sure it's just fine.
Yeah, I think the take-home message would be to have it done by someone who's very experienced, who has good outcomes and can show that. And you have, audited your outcomes and you've been away and studied what is considered a fairly straightforward procedure, but you've taken it to the next level where you're doing quite a state-of-the-art procedure and you've travelled overseas to watch experts in their field do it. So, that's really what you have to do, and you have to scrutinise your own technique and make sure that you follow up your patients and see what the outcomes are.
I think that's very powerful to know your own results and to be able to tell people what your results are as opposed to worldwide literature. I would encourage anyone who's thinking of having not just a vasectomy but any surgery to ask their surgeon, what they can expect from their hands in terms of outcomes and failure rates and complications.
Yeah, because it's considered a fairly straightforward procedure, but it has very significant outcomes if not done correctly.
Absolutely. I think with these procedures that are perceived as being simple and completely safe, there's a risk of falling into the trap of underestimating it and not respecting it and getting back into activity too early and causing complications and having a bad outcome. So absolutely safe and simple if done in the right way and treated with respect in the post-operative period.
So I think that just about wraps up the vasectomy podcast. Is there anything else we should have spoken about? We didn't mention vasectomy reversal, did we?
No, that's a big topic, which perhaps we can talk about another time. But to summarise, vasectomy reversal does work well. There's a 90% success rate if done within the first few years after a vasectomy. But what that means is there's a 10% failure rate. So it can't be relied upon. And vasectomy should absolutely be considered permanent.
Yeah, sounds like a great topic for a future podcast. There's going to be many more to come. Thanks very much for coming along, Trent.
Cheers, Andrew. It's been fun. We'll take off the training wheels next time and make this coffee a double shot.
Sounds great.
Tackle Talk, a men's health podcast, is proudly supported by Perth Urology Clinic, Western Australia's largest urology practice. This podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed by listening to this podcast. The use of this information and the materials that link to this podcast are at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice. Anyone listening to this podcast with a medical condition should seek individual medical advice and should not use this podcast to delay treatment or disregard the information given to them by their health professional for treatment of their condition. The information used in this podcast should not be used as a substitute for expert medical opinion in any medico-legal proceedings.